You're listening to Grown and Growing with Sonia Hamlin. Welcome to the podcast, Dr. Johnson. How are you?
I'm good, Sonia. Thank you for having me.
I'm so glad to have you. I appreciate hearing from the experts. And since you are a OB-GYN, I appreciate your perspective on this very important topic of menopause. It is, I was going to say it's a hot topic, but that's a pun. It is literally a hot topic. I got many questions from people I know who want to know the tea about menopause. But before we get into that, I do want to talk to you a little bit about yourself. You've been practicing medicine for about 20 years or over 20 years?
Yeah, about 20 years, yeah.
And I want to know, why OB-GYN? Why medical school? And why this particular specialty? Why did you want to work with women in this way?
Okay, I'll try my best not to be long-winded, but since this is clearly something I'm passionate about, I knew in sixth grade that I wanted to be a physician.
Mm-hmm.
I wasn't exactly sure what kind. If you would have asked me then, I would have told you I wanted to be a pediatrician specializing in allergies because I suffered from so many. But once I got into medical school and then went through my clinical years, I spent time on general surgery, and it was very evident to me that I am someone who is procedure based. And so I wanted to pursue a field where I could work with my hands and things looked different every day. And then I did my OB-GYN rotation and I had an aha moment that this is a specialty that mirrors surgery and the procedure based, but also it gives me time with women and continuity of care. So if I did deliver someone's child or I did perform a hysterectomy, I see them every year at their annual exam. So I get to watch that child grow. I get to see them when their children are adolescents and deliver grandkids. So I liked the continuity that it brought, but I also liked being in a field where I work with my hands on a daily basis.
Yeah. And you know what? I never thought about an OB-GYN in that way. Like you really do, if you find a good OB-GYN to work with, you work with them for the rest of your life. And you start working with that person, presumably, or sometimes before you even have kids, have kids, and then you have kids. And then, as you grow older, that relationship deepens and it becomes different because you're going through a different stage of life. It really is a relationship that you have long term. It's a relationship that you put a lot of trust in. I know a lot of people like me use their GYN as their primary care. I know it's not the same.
Absolutely. And so that's why we have to know a lot more things than we thought we did.
Yeah.
And the nice thing about the continuity is that you really get to know your patient by the time they get to what we're discussing today. So by the time they reach perimenopause, like you have a good relationship and you've seen them prior to this maybe overheated grouch monster they've become.
Yes. Yeah. And I also want to give you your props because I never really thought about the varied skill of a GYN, right? You come in, you see them, they give you a breast exam, they give you a pap, that you have the pap smear. Then you have a baby and it's like, okay, they deliver the baby. But if you also deliver babies via C-sections, you do hysterectomies, you do other surgeries. It really is like a dual, it's like surgery, but not surgery because you see a lot of women in non-surgical reasons. So I just want to give you your props because when you think about it, it's a position that you need a lot of different skills with. So
yeah, and all of those things, everything you named, is what attracted me to the field.
Awesome.
Yeah.
So let's get into talking about menopause, and I want to start because you study this and you see this every day and you've been practicing so long. Let's start with the basics. Like from your perspective, from the medical perspective, what is menopause? What is our body doing? What is it doing?
Okay, so sure, let's just start with the definition. So menopause means that you have gone 12 consecutive months in a row without a period. And when that day happens, you are no longer able to have children.
Mhm.
So it's always a diagnosis that's retrospective. So we won't know that we're menopausal until the day it's been 12 months in a row.
Wow. Okay. And what are so when I think of menopause, right? Because people use the words interchangeably, but I know there are like three areas of menopause or three stages of menopause. Can you talk a little bit about that?
Sure. So what we're talking about today is perimenopause.
Yes.
So perimenopause means around menopause. So everything that's happening to our bodies leading up to that. And so it's really broken into early perimenopause, late perimenopause, and then menopause.
Okay.
So early menopause means that we're somewhere in our 40s, and that's going to look different for different women.
Mhm.
Um, and we notice that there are some irregularities to our period. And that irregularity can look very different for different people. So it could be that your periods are longer or they're shorter, or they're heavier or they're lighter, or they're becoming more frequent or they're becoming less frequent. Which is why I tell all reproductive age women to make sure that you're keeping a menstrual diary, and that you know when your menstrual cycle comes. So textbook is you're getting a period every 28 days, like clockwork, and it lasts for 5 to 7 days. So when there's a deviation from that in your 40s, then that's usually what we're calling early menopause.
Mhm.
Okay. So to further define early menopause, that means that your cycles are um, varying by 7 days or more. So it's
Okay.
fluctuating by about a week.
Mhm.
Okay. And you can be in this early phase for several years. And then what happens is you naturally transition into the later phase of perimenopause. And now what's going to start happening is you're going to start skipping months.
Okay. Yeah.
So you might not have a period for 2 months or 3 months. And then what happens is you ovulate, and now the floodgates let loose. And now you're bleeding excessively for 14 days. And then you'll go back to not bleeding and you start skipping months again. And then we call you menopausal when we've gone those 12 consecutive months with nothing.
So I would have loved to have the one that skips. That did not happen. I would have loved if it was like 2 months, no period, and
Yeah.
then then it comes. But I didn't have that experience. But before I get into talking about that, what biologically is happening in your body when that is causing your periods to go haywire? Because I noticed around the time when I turned 40 that my periods definitely changed. They became heavier.
Mhm.
And I thought there was something wrong, like there was a fibroid or there was I don't know. I thought there was something wrong with me. I never really thought that it was menopause. And I probably didn't think it was menopause until like yesterday, today. um I didn't know. I thought there was something wrong with me. And that my body was going through something. But what is your body doing? Are your ovaries just saying we tired and we're dying? Like what are they what is
Exactly.
happening?
Yep. So you've got it exactly right. So from the time we're born with however many eggs we were born with. And so we don't make any more. So they get recruited, we ovulate, and then we can potentially get pregnant. So by the time we're um, perimenopausal, so in our over the past age of 45,
Mhm.
the average age of menopause in the United States is 51. The best predictor is however old your mom was when she went through menopause.
Mm,
If you don't know, it's usually 51.5. That's what I tell women. So by that age, the ovaries are tired. There's not many follicles or eggs to recruit, so there's
mhm,
not that many left. Um, and the ones that are left aren't always chromosomally normal.
mhm,
Okay, so our ability to get pregnant declines in our 40s.
mhm. They're what did you say? I'm sorry. The
Chromosomally
chromosome.
they're more likely to be abnormal.
Abnormal. Okay. Okay.
Which is why if so we digressed, but
Yes.
so we call mothers who are pregnant, who are 35 and older, we call them advanced maternal age.
Hmm.
So there's an increased risk when you're advanced maternal age that you might have your risk for having a baby with Downs or having a genetic abnormality is higher,
Hmm.
just because those eggs are older and they're more likely to be chromosomally abnormal.
Okay. So I do want to ask a question about fertility connected to menopause, but let's just go back to duration. I'm also surprised that maybe because I'm closer to 51, I'm 46 now, and 51 just seemed like right there.
Mhm.
I thought it would be like 60, like when you stopped having a period. I don't know why, but it's 51. Like you could be as late, early as 51.
Absolutely. Absolutely. So
Oh.
you're 46, I'm 47. There's women our age who are menopausal now,
Mhm.
and that's still within normal. Um,
Okay.
but to further answer your question in regards to the ovaries being tired,
Mhm.
um, that tiredness really looks like you're not producing estrogen and you're not producing progesterone in the same amounts that you were when you were younger and having regular menstrual cycles.
Okay. And that estrogen is what is that estrogen and progesterone like decrease, I guess, decline is what's causing the symptoms to exacerbate in your body.
Correct. So
Okay.
that decline causes a lot of symptoms, which we'll get into. And then there's also lifestyle changes, the standard American diet and things that we do and things that we don't do, that might make this transition to menopause a lot
Hmm.
harder for
Hmm.
us.
Hmm. All right, let's talk about these symptoms because that's all I hear about. There's somebody very close to me who is going through menopause and it sounds very, I'm gonna be honest, it sounds very miserable. And because this person is close to me, I'm like, is this gonna happen to me?
Yeah.
Our situations are different. She did have a hysterectomy, and I'm talking about my sister, sorry. But she had a hysterectomy, my mom had a hysterectomy, and it is my fear that I'll have to have a hysterectomy. Like, you know, how, if you said that when you are, if you don't know, that yet your menopause situation may look similar to your mother's. Is
Mhm.
that the case, you know, with the problems that she's having too? So if my mom had a hysterectomy, is it likely that I may have to have a hysterectomy? And is there a way to change that if that's not what you desire?
Absolutely. So there is a genetic predisposition for certain things. So, absolutely, if your mom had a hysterectomy because she had fibroids, then you are at increased risk that you might need a hysterectomy, that you might have fibroids.
Hmm.
If your mom had a hysterectomy because she had endometrial cancer,
Right.
then that risk might look different for you. Um, a lot of times, endometrial cancer is like hormone dominated. So if your mother's fluffier or carrying more weight, and might be living in an estrogen dominant state, and that's not your case, then that risk might not be the same for you. So it
Hmm.
depends on what the reason for the hysterectomy was. But oftentimes, there is a genetic predisposition.
Okay. So I've read that the symptoms for menopause are like in the hundreds. Like it's really scary when people are like, when people read off itchy scalp, I don't know, hot. Everybody knows the hot flashes. I think most of the emphasis is on like hot flashes and terrible periods and maybe moodiness. But there are so many other symptoms of menopause. What are the ones that you what are some symptoms that people may not know about, but are definitely attributed to being in perimenopause?
So I'll tell you the major ones I see, is hot flashes, night sweats, trouble sleeping. It's impacting your mood. So anxiety, depression, mood swings. I would say those things that are less common, but are very common that women might not attribute to perimenopause would be fatigue, brain fog, difficulty concentrating, hair loss, um, vaginal dryness, pain with intercourse, more frequent urinary tract infections, and weight gain.
That's awful. And the problem with that I have, I mean, not only is that a long, very long list, I feel like those are all things that can be confused with other illnesses, other
Absolutely.
conditions. And it's
That's
like,
right.
well, how do you know if I am, I guess depression is depression no matter what is causing it. But I
Mhm.
mean, but it's like, how do you cope when you have all of these symptoms and you you want to figure out what's wrong with you. You want to make sure you're not dying. But
Right.
also perimenopause is kind of a mystery. It's not something that is talked about. Do you think that, and I don't know why that is. I mean, I think it's always been seen as a women's issue, a women's disease. But from a medical perspective, why isn't there more research um, on menopause, on perimenopause, and how it affects women of different races? Why isn't there more research from the medical community about it? Or is there and I just don't know about it?
Um, well, that's a loaded question for me because I feel like there's a lot of research and there's a
Okay.
lot of things that are debated in the literature, which
Okay.
makes it sometimes challenging for providers to navigate that space.
Okay.
Where at one point we threw hormones at women, and then studies came out that said that's not what we should be doing. We're putting them at risk, cardiovascular wise. And so now there's literature that comes out that says that a transdermal approach, if we're going to give hormones, we should be giving it on the skin and we shouldn't be taking it by mouth. That's less toxic to the liver, but it also increases the cardiovascular, it decreases the cardiovascular risk that was present when you took it orally. So I think that there's in the medical field, there's a lot of debates within the literature. And then, so that there's some physicians practicing this way, and then there's other physicians practicing this way. And then there's naturopaths that offer something different that's often appealing to patients. So I feel like there's a lot of information and that we don't always know what to do with that information.
Mm-hmm.
I also think that we also don't have safe spaces in community as women where we can discuss and normalize some of the things that we're experiencing. So when we start to experience these things, we assume the worst, or we have catastrophic thinking and think
Right.
that, oh, my periods are heavy now, I have fibroids and I'm going to need my uterus removed, when in actuality this is just a normal process that might take somewhere from 3 to 8 years, and we more than likely will keep our uterus.
Right. And I think, I mean, you said a lot, a lot. But to your last point, I do think talking about it more does help you not feel so weird, right? I mean, because a lot of the symptoms can, they're external, right? Weight gain is external. You see it, sweating,
Yeah.
being tired, being, having anxiety. I mean, I went through a period of brain fog and I was like, and I'm still in it
Mm-hmm.
that worries me. I'm like, do I have dementia? Like, so it is I do think we need to talk about it more to normalize it. Now
Mm-hmm.
to your point about, medical providers having different ways in interpreting the research differently. How
Mm-hmm.
do you handle that in your practice? Like, when you are with your patients, how do you help them through the perimenopause, menopause, postmenopause stages?
Yeah, I think that's a wonderful question. I feel like I approach the patient by meeting them where they are
Mhm.
and establishing a relationship in regards to what it is that they want to accomplish. And I think one of the priorities is shared decision making.
Mhm.
So I don't know that that happens in every office. At least that's my experience in talking with Black women, is that they
Right,
don't feel like they're part of the process. They don't always feel heard.
right,
So my approach is that there's shared decision making, and that I am offering something that you were seeking. So if you're coming to the office and you are leading with, you do not want to take something that's prescribed, and that you are more interested in natural things that can be done or lifestyle changes that can be made, then we will talk about those things. But I will absolutely give you your options of the other things too, so you know what the full gamut of
Right.
resources are, but that you're also aware of the risk, benefits, and alternatives. And I think oftentimes we forget the alternatives because those aren't things that medical school like emphasizes or teaches us. So those are things that we have to be lifelong learners and
Mhm.
like continue to research and continue to learn so that we can offer those things to our patients.
Yeah. And I think you're right. I mean, it's so difficult to find relationships that you trust with your medical providers. I think that's why I haven't had a primary care provider because it's so hard to find a primary care provider where you feel like you are listened to and you're not rushed. That they will follow up with you if you miss an appointment and they will care. And I feel like it's automated, so y'all should be able to follow up if I miss my yearly. I just have like certain, expectations. It has been a long time. And my um relationship with my GYN, she delivered both my kids. I was seeing her before, and then she retired, and I was like, oh my God,
Right.
what am I
Yeah.
gonna do?
What we gotta do?
Um, it's a lot, and you're going through this very important phase in your life, and you really want somebody trusted to go through that with. And so, I think that relationship is so important, and it's good to hear that you let your patient's voice be heard, because I think that's important as
Mhm.
well. So
Yeah.
when we're talking about symptoms, I mean, the number one question I get, well, I get a couple of questions, is, how do we manage the symptoms? Because if
Mhm.
we're going through this 3 to 8 years, that's a long time, right? Because it's a long time to live with this, not only for yourself, but for your family.
Right.
So are there things that people can do to relieve
Absolutely. And I think it depends on what symptoms are plaguing the patient the most.
Right.
And I just want to also offer some hope to those who are listening and watching is that 80% of women make this transition seamlessly. It's that 20% that are having a really, really rough time that we're talking about. We need to like intervene and do something more. And so I think it depends on what your symptoms are. So if you're complaining because your estrogen levels are low, that you have vaginal dryness and pain with intercourse, that's much easier to treat and see success. Or if those patients, because the estrogen levels are low and they're having more frequent urinary tract infections, then that's something that we can treat with great success.
Mhm.
Um, when patients are having hot flashes and night sweats,
Mhm.
the risk of prescribing a medication is a lot different. So
Okay.
that might not be always something that someone wants to take on, or they might have a family history of breast cancer. And so taking estrogen is not something that they're open to at all.
Mhm.
Um, so it depends on what the presenting symptom is. If it's a lot of brain fog, fatigue, difficulty concentrating, then we start looking at are there triggers in our life that we can avoid, or are there
Right.
lifestyle changes that we can make?
Mhm.
Um, so I think it's and I think that's why it's difficult and why we're actually convening and having this conversation,
Yeah.
because there's so many layers that we have to figure out what the presenting symptom is, what's bothering them the most, and then what's the most effective, least risk to the patient to treat the symptoms.
Yeah. And we're learning, and just having a group of girlfriends, and having two sisters, is that everybody's experience is different. Everybody goes through this experience very differently. And so what impacts one person and what works for one person might not work for you. And that's unfortunate because you find this community and you guys are like swapping, remedies, and it may not work for you, which can be, pretty tough, which is why having a relationship with a GYN who listens, and who, listens to what your needs are, is so important.
Mhm.
So
And it might be, like because we're so individual. Yes, I love that we're coming together in community, but we're so individualized, and there's so many different things in our past medical history
Mm-hmm.
um, that impacts how it might show up for us. So if we're diabetic or have insulin resistance, then our symptoms may be way worse than our friend who has a normal BMI
Right.
that doesn't have like certain comorbidities.
Yeah, you know what? That's so important. I didn't even think about that. I'm just thinking biologically we're different, but yeah, we have different weights. We have different, my sister has sickle cell. I don't, right? So there are a lot of things that make us, different. And I may eat, a bit of a different diet. Maybe I'm plant-based, which would
Yep,
make my experience a lot different than
a lot
somebody who
easier.
is not.
Exactly.
Oh, it's easier. So
Yes.
do you fall on that scale of physicians who there are physicians who believe in, hormonal treatments. There are physicians who are probably, like take a wait and see attitude towards hormones, and then there are people who look at, alternative methods, maybe more natural methods. Where do you fall in that spectrum?
I think I fall more towards the latter part of the spectrum, where I would be more inclined to wait and see, or to offer some alternatives that are more natural or not hormonal.
Hmm.
But I also think it depends on how long the patient has been plagued by the symptoms,
Right.
what all they've tried. Like,
Hmm.
are they at their wits' end?
Right. Right. I think that's how it was for me in my period. I was at my freaking wits end. I'm like, how
Right.
long is this period thing gonna last? It seems like it's just heavy, 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 heavy. What I ended up doing is having an ablation because I
Yeah.
was like, and I wish I would have had it sooner, but whatever, it happened when it happened. It's all good now. But if you don't have something like fibroids or PCOS or endometriosis, and you're dealing with a heavy period, I had an ablation. Like, are there other treatments for heavy periods that, which is ablation is considered surgery? It's when they basically take off the lining of your something.
Yeah, they destroy the lining of the uterus,
Uh-huh.
so that you'll have no period or it'll be very light.
Hmm.
Um, so I find that question a little bit challenging, because I don't want to mislead our listeners or
Yeah.
viewers into thinking that this is a straightforward answer. So I think that it's important to realize that when we have irregular bleeding,
Hmm.
there's an extensive workup that happens between you and your gynecologist.
Right.
So we need to figure out, is this a hormonal issue or is there a structural problem?
Right.
So the hormonal issue would be, we would um, get a thorough history from you in regards to what your bleeding history looks like, but we would also get some blood work. So we're looking at hormones. Most specifically, we're looking at your thyroid function, because a lot of times when your thyroid's abnormal, that can affect your periods. It can also be the number one reason why patients who aren't menopausal have hot flashes. So there's blood work and a hormonal component that takes place. And then there's also, is there a structural reason for why you're having irregular bleeding? So an ultrasound or would take place, and we're looking to see, do you have fibroids? Do you have polyps? Is there something that's causing these heavy periods? So in your case, it sounds like there would have been a hormonal workup that was normal,
Hmm.
and then there would have been they take a look and make sure that the uterus is structurally normal. And if
Right.
those things are normal, um, and you're at low risk for endometrial cancer, then you're a great candidate for an ablation.
Hmm.
Um, but like all of the workup has to be normal to proceed in that direction.
Okay. So you bring up a good point about thyroid, because I was like, oh, wow. I mean, so what battery of tests should you be having? Just when you turn 40, you're definitely perimenopausal. What should you be checking on a regular basis? Or working with your doctor? What kind of tests should you be having?
Okay, so I would say to empower our to empower the patient is knowledge of self.
Mhm.
So to have a clear knowledge of what your body does on a regular basis. So if that's writing it in a diary, or if you want to download an app, a period tracker, that is most excellent when patients bring those, because then we have like a hit. We're not sending you home to keep a menstrual diary. We already have months, so we're a lot further in the workup than if you present it without it. So I would say knowledge of self first. So when there's a deviation, when the periods deviate, if you know, then you're more likely to get in with your physician sooner.
Mhm.
But I would say as long as you're having an annual exam in your 40s, then the things that we would be looking for is we would be checking your thyroid. We're not necessarily checking hormones if you're
Right.
still having regular periods. And we're not necessarily checking hormones even if we think you're perimenopausal and they're starting to become a little bit irregular. Um, I think usually it's when it's problematic that we start checking things of that nature, typically a FSH, so the follicle stimulating hormone, which is the hormone that's responsible for helping your eggs mature.
Mhm.
Um, so that's typically what we check. The problem is that the ovaries are putzing out. They're not stopping working. So sometimes you're ovulating and sometimes you're not. So that FSH level is going to fluctuate. So we can't rely on one level being high and then telling you you're menopausal. It's
Okay.
really going to have to be something that we track over time.
Okay. When you are, so we talked a little bit about this at the beginning of our conversation. The If you are perimenopausal and you're in your 40s and you still would like to have children, how does being perimenopausal affect fertility? Like
Okay.
yeah,
So
I'll just
there's a rapid decline in fertility past the age of 35. So
35.
35.
Okay.
So if you're in your 40s, then you're going to want to know, you're going to want to meet and have a preconception counseling visit with your OB-GYN, where
Mhm.
they look at your family, they look at your family history and your medical history, they look at your partner's medical history, and then they can weigh in on what it is that you need to be doing ASAP. So we tell patients that if they're 35 or older and they've been trying to conceive and they've been unable to conceive and it's been 6 months, then you need to see your OB-GYN sooner than later.
Mhm.
Okay. If you're less than 35, it's 12 months of
Okay.
unprotected intercourse. If you're not pregnant, then that's when you would start an infertility workup.
Mhm.
So we're a lot more aggressive when you're over the age of 35. Um, so what happens is you have decreased ovarian reserve. So it becomes more difficult to achieve pregnancy. And then the concern is that the chromosomes might not be normal. So those are things to keep in mind. The other thing is if you're 35 and maybe you haven't met your life partner yet, but you know you want children, I would still have that visit with the OBGYN. They can talk to you about like egg retrieval or freezing eggs or things of that nature. Because if you freeze your eggs at 35, when they thaw them out, their age is
Yeah.
still 35. But if you're 42 and trying to achieve pregnancy, those eggs are 42.
Yeah.
Um, so I think those are like things to consider and to keep in mind.
Yeah, it's interesting because they talk we there's a lot more talk about freezing your eggs now. And I think, for people who are our age, I'm like, when we were 35, I didn't hear about it as much. And I know I have
Right,
friends who wish they had known because
right,
I do have friends who are trying to freeze their eggs at 40, 42, and it's a very difficult process. Like, you don't get as many eggs, and the
right,
process itself is very hard. um Fertility in general is always in the news. It's a very interesting thing because I think psychologically we know that the older we get, the harder it will become to have children. But then there's also science, right? Science
Right.
is over here doing this thing with IVF, and then you hear Janet Jackson, Tamron Hall,
Mhm.
all of these women who are 50 and having kids, and that just gives you so much hope. But we don't, the problem is we don't really know what Tamron Hall did or Janet
Right.
Jackson.
We don't know if their eggs, donor egg, if their eggs were frozen. Yeah, we
Right.
don't know. We just know they have a baby
We
at
just
that
know
age.
that they have a baby at that age. And so I do know a lot of my friends who are my age who still want to have children naturally. Um, it's not, I guess it's not impossible, but I guess your chances are much less just based on, what you said about your eggs and how much you're producing and then the quality of your eggs um at that time.
Right.
So
I'm trying to recall the percentage and I don't
mhm,
want to misquote it, but I know like in your 20s and early reproductive years, um, like each cycle, there's a 1 in 4 chance that you'll get pregnant.
mhm.
And then that declines over 35 to 1 in 10. So
Wow.
yeah, just to put it into perspective.
Okay. So let's talk about what you can do on your own, right? I know there are, lots of medications. I am inclined not to take medications. I just, would prefer to try to do it naturally, even if it's slower. What should we be doing to take care of ourselves and our like gynecological health at this age? What are some things that we could be doing naturally that will put us at a advantage when we're going through menopause or perimenopause?
Mhm. So I would say maintaining a healthy BMI would be the first thing that we could do. Also, making sure that we're incorporating some type of movement in our daily life. So it doesn't mean that you have to be a runner, but walking or like some type of movement, whether that be stretching, meditation, breath work. Um, those are all things that we can be doing. Those are all things that decrease cortisol, the stress hormone. Um, there is some evidence and research that links um, high cortisol and high stress levels to making that transition to menopause a lot more challenging and difficult on us. So I would say other things that we can do is to know our triggers, especially if we have vasomotor symptoms, so those hot flashes and night sweats. If there's a trigger, and to know what it is and to avoid those things. So for some women, caffeine is a trigger.
Right.
Um, for others, it's alcohol or food sensitivities like dairy can be a trigger for vasomotor symptoms. Other triggers would be a big one that we don't talk much about, but refined sugar or simple carbs. Those tend to make our body very acidic. Um, those tend to lead towards insulin resistance, which
Right.
um, wreaks havoc on that stress hormone. If you're a smoker, stopping smoking is going to help significantly with vasomotor symptoms. And then for some women, hot and spicy foods makes their vasomotor symptoms off the chain. So if you can like keep a food diary or keep a diary of is there something it was that you were doing right before that triggered it and avoiding those things, that would be helpful.
Yeah.
Dressing in layers is something that we can do because sometimes we're burning up and sometimes we're cold, and so those are some easy things that we can do, especially for those women whose transition to menopause doesn't take that long. But for those whose it's dragging on that 5 year range, that might be when we need to look at some other things. But
Mhm.
I would say the big things are knowing your triggers and also stress management.
Right.
So um, I think the third thing would be like supplements. So making sure that you're taking a multivitamin, making sure that you are getting your omega 3s. So like um, DHA or eating more fish, adding more fish in your diet. Those things help significantly in the perimenopausal period. And then the third supplement I would tell women to make sure that they're taking is vitamin D.
Okay. So, can you repeat those? Vitamin D, omega-3, and a
Omega-3
multivitamin.
and a multivitamin.
Okay. Yeah, I mean the frustrating and but also good thing about it is that it always comes back to lifestyle every
Yeah.
time. Like
Mhm.
every time it comes back to what are you eating, right? How are you
Right.
moving? And what is the stress like in your life?
Right.
And
So I think, yeah,
go ahead.
that when you said that, it just makes me think food is medicine. Um, so um, that's my philosophy. If we can uh, if we can start looking at what we ingest and food
Right.
as medicine, then I think that will help us. But that just hasn't been our lifestyle. If there's a problem, we look for a pill to fix it.
Yeah.
We're not necessarily looking at like eating the rainbow on our plate and how that benefits us long term, or how eating things with life that are green is going to benefit us long term.
Yeah. It does. And I think at this age, number one, your body starts to rebel towards that food anyway. Like
Mhm.
your body will tell you what it does not like.
Right.
Um, in very like it used to be very subtle, but now, when I'm in this age, I'm like, I can't even look at a McDonald's. It's like your body just automatically knows that no, I don't want that. And I think it's a combination of it not being good for you, but also the food that we used to eat when we grew up is not the food it's that we're eating today, even though it still
Right.
says McDonald's. That food is not the same.
It's very different, absolutely. And
Uh,
and it's and it's filled with hormone disruptors. So it's filled with chemicals that disrupt our hormones, which is why I feel like there's more angst as we go through this transition.
can you talk about that more? There
Mhm.
are hormone disruptors in the food because it's
So like
made in a factory or because it's not natural.
preservatives, additives that are added, um, plastic, or that's why you'll see this huge initiative to drink things out of glass bottles, or to drink things out of like these Stanley cups and things.
Mhm.
Because there's this concern that plastic um, disrupts our hormones.
Hmm. And that, like I see on in the news, like there's microplastics in everything,
Mhm.
like in our food, and they're finding it like in our body, which is crazy to me.
Which is crazy, right?
Yeah.
Or like all of a sudden, like no, like all of a sudden you're looking around and things are BPH free, but nobody ever told us what BPH was,
Right. What is
right?
it?
And what it does to us, and that it disrupts things hormonally. So
Mhm.
it's, yeah, just because I think that it would create alarm, and there'd be a lot of social accountability if you led with
Right.
this is BPH and this is what it does to you. So now it's just, oh, this is BPH free.
Right. Right. And what is BPH? So, like you said, excuse me. So what kind of parting advice do you have for us? Like when we're going through perimenopause, like what didn't I ask that women should know about, should be not concerned about, but should be higher on their radar? Um, is there anything? I'm sure there are.
So I think that coming together in community is most important. So, like, I think that that's even how we led. You had questions. Your sister's going through this and has questions.
Yep.
So I feel like if we could come together and be in a room or in a Zoom or
Hmm.
in a in a supportive environment, the wisdom is always there amongst the women. So their experiences coupled with what they know it's going to be, or what they've heard, or what their physicians told them, or what their mom told them, like those are all things that we can gain hope, and we can gain strength from. So I would say don't go through perimenopause in a silo by yourself.
Right.
You will lose your mind. So I would
Literally.
say making sure that you're connecting with women that are going through the same things, because some are going to give you hope because that transition wasn't as terrible for them, and then some have their fan that they pull out their purse. It's like all the time, and so they're giving you ideas of things that can help you should your symptoms present like this. So I would just say those are my parting words, is to not go
Yeah.
through this by yourself, and then to normalize it for the next generation. So talk to your daughters about it,
Hmm.
what your symptoms were, when they started, and what worked for you.
Yeah. So yeah, we did touch on that. We talked about hormone treatments. She says, you know, why I told you her question was, why is there no medical coverage for it? Why aren't we talking about this more? Because it's so life-changing. And she said borderline torture.
Yeah.
And then her last question was really about when menopause ends. Does it end gradually or does it end abruptly? That was her last question.
So I would say it's going to end gradually, because we call it menopause. You're menopausal the day that you've gone 12 months in a row without a period.
Mhm.
So over those 12 months, I would call that gradual. And some women have symptoms and some don't. And most women's symptoms are very mild in that 12 months, but it's definitely a gradual process. Perimenopause, if you look at it in the literature, it's going to tell you anywhere from 3 years to 8 years.
Okay. What is life like after you have like after that 12 months? Are you like, oh, or is it like a
Yes,
whole set of new problems?
absolutely. You're like, what? Because a lot of that stuff, it left, but some of it remains. So carrying more weight
Midsection.
in our abdomen, unfortunately that stays. Or it be more challenging to lose weight than it was um, premenopausal. Those things stay. But as far as sleep hygiene is much better, the vasomotor symptoms are gone. You still don't have estrogen at all in high amounts. So the vaginal symptoms will remain. So vaginal dryness or more frequent UTIs, that's going to be something that will need to be treated long term.
Okay. That don't
Yeah.
sound too much. That
But
sounds
other things are going to come along with it.
okay.
So, especially weight bearing exercises become way more important when we're postmenopausal. So,
Mhm.
after you've gone through menopause, you don't have estrogen. Estrogen is the hormone that's responsible for keeping our bones strong. So, it's
Okay.
important that we're getting vitamin D. It's important that we're getting calcium. It's important that we're doing weight bearing exercise, things that will keep our bones strong. Because the last thing we want to do is live in Northeast Ohio, where I am, slip
Yes.
on some ice and then break something.
Yeah.
Um, so it's going to be important that we're keeping up with those supplements that we were taking in the transition, but vitamin D and calcium become way more important when you're menopausal.
Hmm.
And that's when your provider will start ordering DEXA scans, where they look at, how thin or how strong your bones are.
Okay. And then this is my last question, I promise.
Mhm.
Do Black women experience menopause differently than white people or Asian people or Hispanic people? Do we? I feel like every time it's like, well, Black people is worse for y'all.
Yeah.
Is that the case?
I find that health disparity for Black women to cross everything in medicine that we do. So, diabetes is worse for us, breast cancer is worse. Absolutely, I will say that in my experience, um, that transition is challenging for us. There is definitely women who, um, by race or ethnicity, make that transition a lot smoother. So we do know that our female counterparts in the Far East have way fewer vasomotor symptoms than we do. And we think it's because they eat a diet higher in soy than we do. So they're exposed to phytoestrogens, so estrogen from plant sources that we're not necessarily exposed to, but it's not something that we can just ingest. This is like their lifestyle over years that they've accumulated. So um, yeah, I do think that we as a people have a tendency to experience things um,
Yeah.
way at a higher capacity than
Yeah.
others.
And so this is no different. And I appreciate the advice because you definitely want to know what medication is out there for you, but at the end of the day, it always comes back to your lifestyle. What are you eating? How are you moving?
Right.
Are you letting this world like stress you out? It's very easy for that to happen.
And what are we carrying? So what are we
Yeah.
carrying? I don't want to minimize our behavioral health and mental well-being. And I don't know that traditional medicine does a good job of tailoring treatment to the body along with the mind. So, what is it that we're carrying that we need to let go of?
Mm-hmm.
So I think that's important for us to sit with.
Well, thank you, Dr. Cheryl. This was a great conversation. How can people find you? You have a practice in Northeast Ohio. We're both from Cleveland. Yes.
Yes.
Where can people, if people were interested in your services, where are you practicing?
Well, thank you, Sonia, for having me. I practice at Summa Health System, so it's Akron City Hospital, Summa Health System in Akron, Ohio.
All right. It was so great to have you on. I know this information will help a lot of women. So thank you so much.
Thank you, Sonia. Take care.
Thank you. And for everybody else, I will see you next time.